Hi, I'm Dr. Prasanna Kumar, endocrinologist from Bengaluru. Welcome for this case discussion. Today we are going to discuss a case of type 2 diabetes who is poorly controlled with metformin and sulfonylurea and also is getting hypoglycemia. Here is 50-year young diabetic, runs 2 years, and he has come with frequent attacks of hypoglycemia in the last 2 months. He is on metformin 1000 milligram twice and sulfonylurea, that is glimepiride 2 milligrams twice a day. His A1C was 8.2, obviously not well controlled. EGFR 88 per ml per minute per square meter of the body surface. LDL 90 acceptable. HDL 36 slightly less. Triglyceride 126 is all right. Creatinine 1.1, and you will see that everything is fine. BMI 31, that means he is obese because Asian and Indian BMI should be 23. Anything above and equal to 25 is obese. The blood pressure is normal 120 by 70 millimeter. Heart rate 78. Latest studies have shown it is better to achieve 120/80 blood pressure rather than 140/80. That 20 millimeters make it. Let us look at this case. Optimized glycemic control with cardiorenal protection is the primary aim of treatment. It is not enough to control the blood sugar. That A1C depends upon each case. In this case, he is not so old, he is in 50 years, no other condition, morbid conditions, serious diseases. A1C of less than 7 is appropriate, and on the basis of provided judgment and patient preference, even A1C of 6.5 also may be good enough if we can achieve it safely without hypoglycemia. 7 acceptable, 6.5 very good, provided this patient does not get hypoglycemia. As you know, in the last 1 century, diabetes has reached a very epidemic proportions globally, and India as such is also increasing. And we Indians have a tendency for earlier onset of diabetes. Diabetes occurs 1 decade earlier than in the European and other Caucasian population. And this 1 decade early onset of diabetes leads to accelerated risk of developing other complications, whether it is micro or macrovascular complications. Thus, strict glycemic control is very important in the management of type 2 diabetes. Of course, we know sulfonylureas play a very important role in the management of control. It's one of the most powerful ones. As a direct extension of their mechanism of action, however, risk of hypoglycemia is increased, and this risk may be further increased in patients with renal impairment, which is a comorbidity often associated with type 2 diabetes. Of course, hypoglycemia is a major concern for users of sulfonylurea. The magnitude and severity of hypoglycemia and induced by sulfonylurea is also something which is widely seen in many studies. There is a strong rationale of combining DPP4 and CV protective, that is SGLT2 inhibitors, in patients with type 2 diabetes. Why? Because these two drugs work synergistically and they exert different and complementary glucose lowering effect. SGLT2 predominantly acts on the kidney and excrete glucose. Normally you excrete 3 to 5 grams, but when you take SGLT2, 30 to 40 grams of glucose is excreted, thus it has a glucose lowering effect. And this effect is independent of insulin. Further increase in the glucagon induced by SGLT2 may be blunted by the DPP4. Thus, the side effect of SGLT2 are lessened by DPP4, that hyperglucosemic. DPP4 are weight neutral, SGLT2 reduces. And both of them synergistically can reduce the blood sugar to a great extent without causing hypoglycemia or minimal hypoglycemia. All the clinical evidence has shown this combination of SGLT2 DP4 is an effective option for management of type 2, providing A1C reduction anywhere between 1.1 to 1.5%. And also weight reduction 2 to 2.5 kg when it is added to metformin. And of course, even today, metformin is the primary medication along with lifestyle modification when diabetes is diagnosed. Of course, the ADA, the American Diabetes Association, recommends initial combination therapy to be considered in patients with A1C 1.5 to 2% above target. So here is our patient who is on metformin sulfonylurea, getting hypoglycemia, not reaching target. What we should be doing in this case is stop sulfonylurea, continue metformin 1000 milligram twice, and prescribe him a combination of SGLT2 and DPP4 inhibitors. This unique combination itself is readily available And for early treatment, intensification because of its good tolerability, very low risk of hypoglycemia, and also 2 to 3 kg of weight loss. That is how the burden of the pill for diabetics will be less when you use this combination. So metformin twice a day and SGLT2 DPP combination will be ideal. You need only 3 tablets to achieve a good control. All these guidelines say only 3 drugs. There is no place for 4 drugs. If you add a fourth drug, it's not going to improve anything better at all. That's why a reduction in the incidence of genital infection is associated with SGLT2. But when it is added with DPP4, then you see that genital urinary infections are probably because of better glycemic control. Also, there may be other mechanisms where probably the infection rate is less. That is how DPP4 inhibitors may contribute to lessening of one of the side effects SGLT2, urinary and genital infection. Thus, our patient was started on a combination of DPP4 and the SGLT2 inhibitors, and his A1C at the end of 3 months came down to 7, which is acceptable. He was already overweight with a BMI 31, and his BMI came to almost 28. Still not very good, but further diet exercise will reduce. Thank you for your attention. This is what I wanted to share, a case of diabetes treated with metformin sulfonylurea, not controlled, obese, getting hypoglycemia. When he was removed from sulfonylurea, continue metformin with a combination of DPP4 SGLT2, he improved better. There is a weight loss. He reached the target without any side effect. Thank you.